Once again, hello everyone. My name is Sandra Morovic, and the idea of this presentation is to guide us through the new CCSVI criteria for ultrasound screening. Okay. So just a reminder that CCSVI, or chronic cerebrospinal venous insufficiency, is a syndrome characterized by stenosis or obstructions of the internal jugular veins and or azygous veins with disturbed flow and formation of collateral venous channels. Most common venous lesions are truncal vascular malformations as intraluminal defects or segmental hypoplasia. Up until now, we have catheter venography, which is considered the gold standard for determining the anatomical site and the type and the extent of lesions that are produced by CCSVI. But catheter venography is invasive and it's not suitable to be a screening method. That's why, on the other hand, we have ultrasound as an ideal screening tool. It is a non-invasive method. It can be performed at bedside, and it allows a real-time assessment of the venous status. Ultrasound's high sensitivity and specificity make it a valuable diagnostic test. And we hope that in presence of this, catheter venography will only be needed when we make a decision for the intervention. In order to ensure a high reproducibility of duplex scanning with comparable accuracy and results between centers, we developed recommendations with a detailed protocol and standard methodology and criteria. All this happened last year at the first ISNVD meeting, which took place in Bologna in Italy. And as we can see on this slide, there were more than 7 international societies participating in making the consensus and making the protocol. I would just like to go over the 5, I will call them old criteria. The first one was considered to be reflex present in an outflow pathway of internal jugular vein and or vertebral veins with the head at 0 and 90 degrees. The second one, reflex in the intracranial veins, deep cerebral veins. Number 3, high-resolution B-mode evidence of proximal IJV stenosis and other B-mode anomalies. Number 4, flow not Doppler detectable in the IJVs and or vertebral veins despite numerous deep inspirations. And number 5, a negative delta CSA in the internal jugular vein. These criteria still exist, but they have been upgraded and updated last year at the meeting. So now I will go one by one criteria with some examples. Criteria number 1 says that it is a bidirectional flow in one or both in the internal jugular veins, in both postures, or bidirectional flow in one position with absence of flow in the other position. And B, a reversal or bidirectional flow in one or both vertebral veins in both positions. On this picture here, you can see in the top left corner a spectrum of normal flow with an insignificant reflex. The middle picture shows just some bidirectional flow. The duration is less than 0.4 seconds, while the third one shows a real reverse flow, which would be considered as a positive criteria. It's longer than 0.88 seconds. Now, if we wonder why it was taken the cutoff value of 0.88 seconds, this goes back to 2005, and the main author was Nedelman. And he concluded in his work that the duration of the retrograde flow clearly discriminates competent and incompetent valves. On the basis of their results, they provide the cutoff values that help differentiate physiological and insufficiency reflex. They use the cutoff value of 0.88 seconds. Why? Because what they measured was that all valves closed properly between 0.22 and 0.78 seconds, and that insufficient valves took time between 0.23 and 6.5 seconds. So we say that criterion number 1 uses the value which ensures enough time for the backflow duration if the valves are competent. So retrograde flow duration longer than 0.88 seconds points towards valve insufficiency. Over here, if you compare the left to the right side, you can see, the right side, the reflex in the internal jugular vein with the probe in a transverse position. You can see the blue color being the normal venous flow, and the red part, which is pointed to by the arrow, shows the reflex. This is another example of the retrograde flow. Again, the transverse position, you can clearly see the difference between the normal and the reverse flow. Here we can compare the left and the right side. This is just one example showing us how we have to be careful during the examination. So on the left side, you can't see the reverse flow, but the PRF value is too high and the PRF is set in the wrong way. On the right side, with the correct PRF, we can clearly see the reverse flow in the internal jugular vein. Here is a little movie showing the importance of the adjustment of the PRF. And if you look at the right side and follow the right side of the screen, you will see how by lowering the PRF, the reverse flow will show on the screen. Now when it's 0.7, you can clearly see the red part, and even 0.5. Okay. Now this is another example of the QDP imaging, the reversal or bidirectional flow in the vertebral vein. Now I'm sorry, but here the first goes the right side of the screen, then the left, but you will see shortly the movement on the left side, but the movement corresponds to the vertebral vein, which is a little bit lower on the right side, so not to be mistaken for the carotid. Now we can move on to the criteria number 2, which is from last year considered to be an additional criteria due to the availability of the software methods and the machines available in certain centers. It is considered to be bidirectional flow in the intracranial veins and sinuses. So here are two examples. On the left, you can see the example of the reflex. The blood flow at the level of the superior petrosal sinus shows opposite directions between inspiration and expiration. If you take a look on the bottom picture, you will see that there is no reflex because the blood flows in both directions during inspiration and expiration at the level of superior petrosal sinus. Oops. Here is another example of the reflex at the level of superior petrosal sinus. On the left side, we have the image during inspiration. On the right side is the image during the expiration. This is a QDP method, but you can see the direction of the flow changing. Another example, again, on the left side, the physiological monodirectional flow. And on the right side, the anomalous bidirectional flow with the reflex. This is a positive criterion. Why? Because physiological intracranial venous flow is always monodirectional, and the setting of the reflex time to a value of 0.5 seconds is considered a positive criterion. Criterion number 3 also has an A and a B point. A is the reduction of the internal jugular vein cross-sectional area, the CSA, in supine position to less than 0.3 centimeters squared, which does not increase with Valsalva maneuver, which is usually performed at the end of the examination. Or B, intraluminal defects such as flaps, septa, or malformed valves combined with hemodynamic changes, which can be a block, a reflux, increased blood flow velocity, and also here in number 3 we have valve leaflet immobility confirmed by M mode. Over here on the top picture, you can see an example of a cross-sectional area which is reduced. It is less than 0.3 centimeters squared. On the bottom side, there is a show of an intraluminal defect shown by B mode imaging. Why the area is taken to be important if it is less than 0.3 centimeters squared? All this takes us back to a Liechtenstein study. It was an ultrasound study of 160 cross-sectional areas, measurement of the CSA in healthy subjects. What they found that only less than 23% of these subjects had a cross-sectional area which was less than 0.4 centimeters squared. But this was a study done in people in the intensive care unit. So they're also explaining that a certain part also of these 23% were hypovolemic maybe, so that explains the lower area. Also in the study they showed the dynamic maneuvers did not affect the asymmetry, the venous asymmetry. 1/3 of their patients were mechanically ventilated, and it still left a large enough number to compare it to healthy subject. So diameter measurements. Because of different vein diameters along its length, the same point of measurement was proposed, and all measures were taken at the level of the thyroid gland. This would be the J2 point for all the measurements in our studies. Here is an example of an intraluminal defect, again shown on B-mode imaging. It's a septum in the internal jugular vein. This is just the same picture, one with color, one without. Again, a septum in the internal jugular vein. Now this will move. And now while it is moving, what you can see is that it is not just the valves and they're not closing properly, but it's an immobile part in the vein. This is an example of stenosis in the internal jugular vein. And again, we can see on the moving picture that the vein is not opening, confirming the diagnosis of stenosis. Now, something about valve mobility, which was introduced last year to the criteria to be examined by the M mode. Left-hand side shows a normal valve, and it is open during inspiration. And on the right side, we can see the same normal valve closing during expiration period. Now, this is the M mode. If you look at the arrows point to a hyperechoic line, which corresponds to a valve. And on top, you can see the line is moving, therefore meaning that it is a mobile valve. While on the bottom picture, it is shown that the valve is immobile, because there is no movement of the line. Now we move on to the criterion number 4, which says that it is absence of detectable flow in the internal jugular and or vertebral veins, despite numerous deep inspirations in both sitting and upright positions, or in one posture, absence of detectable flow in the internal jugular vein and or vertebral veins, despite numerous deep inspirations, and bidirectional flow detected in the other position, same side. So here's an example of an undetectable flow. This is a longitudinal scan of an internal jugular vein with a PRF set to the 1.2. Why do we consider this positive? Because in normal subjects, this finding was only observed with the head in one position, but never in both positions. Criteria number 5 is about the cross-sectional area, and it says that cross-sectional area of the internal jugular vein is greater in the sitting position than in the lying position, or it appears almost unchanged despite change in posture. So here on the top picture you can see the example of the CSA measured in the supine position, and it is 23.91. While in the sitting position, it grows to the 29.0.6, and this is, so the top is the supine position, and the bottom is the sitting position, and it should be reversed. In normal subjects, the sitting cross-sectional area should be lower. Why it is positive? Because a physiological shift of cerebral venous drainage from the jugular to vertebral venous system occurs in postural change from supine to sitting position. The cross-sectional area measured in supine should be greater than cross-sectional area measured in the sitting position. So in healthy individuals, the CSA in supine, when we subtract the CSA in the sitting position from that, we have to get a positive value. Therefore, meaning that negative delta CSA in certain individuals points towards loss of postural control of the predominant outflow route in supine position. Here, this is the two pictures of the same patient, and you can see the example of the cross-sectional area in the supine and in the sitting position did not change. It is 0.03 in both positions, making it a positive criterion. For this whole examination, all measurements have to be performed on both sides in both positions, the sitting and the lying position. And we have to remember that criteria number 1 and number 4 are positive only if they're present in both positions. And we have to remember that at least 2 criteria have to be positive for a diagnosis of CCSVI to be considered. Performance of CCSVI screening by following these recommendations ensures high reproducibility of duplex scanning with comparable accuracy between centers. Thank you.
We decided with Dr. Ascal to have questions immediately after each presentation. So you have some questions about the presentation of Dr. Morovic. Please go to the microphone and ask. So it seems okay. Give your name and institution and whatever before.
Okay, Karen Marr, Buffalo Neuroimaging Analysis Center. Your criteria 3, stenosis. You mentioned later on criteria 1 and 4 have to be in both positions. What position for criteria 3 for stenosis? If you had stenosis in upright, is it still positive?
Criteria number 3. Oh, it's not opening. Okay, just 1 second. Okay, for the criteria number 3, we said there is a reduction of the CSA in supine position and it is not changed by the Valsalva maneuver. And B, the interluminal changes. Of course, the interluminal defects are probably seen in both positions. But you asked me, sorry if you can repeat the...
Okay, for the stenosis section A only.
Okay.
If it was in upright position, you saw less than 3 millimeters squared, would it be a positive finding?
Yes.
That just seems, as somebody who works with jugular veins all the time, that seems to me maybe the Achilles heel of these criteria. First, because it was based on, and also because we see such enormous variation in patients on a routine basis or their clinical condition that I wonder how long that one's going to be able to stand alone. Do you have any thoughts?
Yes, I agree with you. There is great diversity between patients and everything, but I think there's also a point that we have to start from. So I believe that also after today we will be smarter with more examples and maybe this will be changed to something else. So
maybe in the future we can put for centers to be sure to document which position it is in so that we can recheck our findings and see whether that is significant or not or relevant.
John Cook, Stanford Cardiovascular Institute. Thanks for that very nice presentation, Dr. Morovic. I had a question about the mechanism of, I believe, criteria 4. It was the criteria that the normal reduction in IJ diameter is reversed with the sitting position. So normally in the sitting position, you have see more of the flow going through the vertebral veins. So what is the mechanism by which that normal response is reversed in CCSVI? Could you talk a little bit about that?
I'm sorry, I'm not sure I understood exactly what you're asking. If you can repeat the question.
The question is why do we have a collapse of the normal?
Sorry. Why the reason that the blood changes direction is the gravity and the muscles also compressing the internal jugular vein. So I think that would be one of the mechanisms.
I understand the normal physiologic response. How is that reversed? What is the mechanism by which that is reversed in CCSVI?
Obstruction below.
Yes.
Okay, I'm sorry. The reason we would have a change in blood flow would be an obstruction in the internal jugular vein, which would be...
If you had an obstruction not compensated by collateral circle, when you change the position, the bottles cannot empty, and you have an increase in the cross-sectional area.
Okay.
This
So
cannot be possible if you have, for example, something like a substitute circulation that may prevent this effect. But sometimes you do not have effective collateral circulation. So you change position, and the jugular vein cannot drain for a certain time, and you have a cross-sectional line enlargement.
Thank you.
Cross-sectional area.
Professor Nicolaides.
Congratulations. I very much enjoyed your presentation. You have summarized the document very well. It's a year since we produced this document, and we all went back home and we started measuring velocities at J1, J2, J3, and so on, and making more observations. And some of us begin to feel that perhaps the time has come to start thinking not only of these criteria that work very well for diagnosing CCSVI, but for thinking about criteria for individual lesions. For example, criteria for diagnosing jugular vein stenosis, criteria for diagnosing a septum or abnormal valves at the lower end, and so on. I'd like to hear your thoughts along these lines, because we have to start thinking about the update of this document.
Exactly. That can be the next document. And I agree with you completely that there are a lot of unsolved issues still going on. And with every new thing we find out, again, many, many questions are raised. So.
Yeah, the problem with velocity, I think that at the time of the consensus, we did not have enough data about this fundamental problem. And so we need more and more publication measuring this parameter. And this was addressed in the document printed in International Angiology very well, and we hope to have data from everybody about this.
So Elias from Athens. About velocities, I think it makes sense when we have big differences in velocities between two different points in the same vessel. And in many cases, we can see these things. So I absolutely agree with Professor Nicolaides. The second one is about the criterion 3. We used the term almost unchanged. I think we have to revise this, because almost it's a little bit
Not exactly.
word with many.
Thank you. Regarding the measurement of velocity, Nikos, really, I would like to think, to say you this. In physiology, you have an increased time average velocity and peak velocity from J3 to J2 and from J2 to J1 due to the aspiration of pleural negativity. So this makes very difficult to measure, because in physiology you have a natural increase in velocity along the jugular vein and also in Q. So we really need to have physiology and to understand when increased velocity means something abnormal due to pathology inside of a vessel, I think.
You know, we have a parallel to this when we think of velocity measurements in time in the liver in surgical or percutaneous shunts, where we can have a mid-stenosis and have an acceleration, or a distal stenosis and have a velocity reduction in the middle. And they're both flow reduction, but depending on where you measure, if you make individual lesional measurements, you have a completely mistaken idea. And in fact, we don't care about velocity, we simply care about pressure in those situations. So we're still inferring something by saying that velocity and velocity individual points is a surrogate for cerebral blood flow or whatever else. It feels like we're still trying to approach the actual measurement by talking about these criteria that we're stuck with for a while, but are trying to get past.
If I can just add something, I think that in what you were saying, it's the point is that one person who is doing the exam has to examine the whole jugular vein and both sides and actually make a decision on whether we'll consider something too fast or too slow based on the whole picture, not just one value of the...
And that's been seen in some of these other studies. Again, not to say that the liver is analogous, but there are some analogies in terms of single and multiple vessels that are used to describe a whole system where there are the same kind of criteria, and in the end result with this criteria, the most useful thing was operator impression of all of them.
Yes.
That's what you're saying as well.
In a way, yes. With a scientific approach and knowledge.
Very, very quick question, Karen.
Yeah, Karen Marr, BNAC again. A point just on your talking about velocities and volumes. I think you have to be very careful when you're in the jugular vein where you're measuring it from. Once you get below the facial vein, you have increase from the facial vein. Now you have a superior thyroid vein coming in. It's increasing pressure, volume, time. You have your mid-thyroid entering. All those come into being factors when you're measuring velocity and volumes. That's not my question. I just had a comment on that. Also, question about where you're, in your talk you talked about measuring the CSA. And before we had it that it was at the narrowest point. Okay. Now you're saying to measure it at one specific location. But it might not be the narrowest point. So the principle of it is to find the narrowest point. So I'm not sure why...
Okay, but... sorry.
Yeah, why you would stick to one specific area.
Okay, I would stick to one specific area so that all of us know exactly the point where it should be measured. So, but if we're looking for the narrowest point, it would mean there's a stenosis. So I would maybe look at that as an intraluminal defect, not as a measurement of the cross-sectional area. So I would separate those two. I would take the J2 point as a J2 point for everybody so that we all follow the same criteria. And if the narrowest point is found somewhere else, I think I would consider it a stenosis. And
but if you had a stenosis at the narrowest point and it was due to, say, an annulus, okay, and when you sat the person upright and took your measurement again, you need to compare to that because, yes, it's a stenosis, but it's also your CSA won't change there. It might change in other positions.
I agree with you, absolutely, but that comes back to my comment that we have to examine the whole vein, and of course there's some protocol, I don't know if I can call it protocol violation or something, but if you see something strange, you will examine it, even though if it's not written in the 5 criteria.
You're really talking about very complementary things, which is identifying the area of maximum stenosis and having uniform reporting of data that will allow inter-site comparison of information and ability to make larger, ultimately perhaps meta-analyses. So it doesn't minimize what you're saying, but both have to be accomplished. There still has to be uniform measurement in every patient, and that happens to be the point that you're describing.
Thank you, Dr. Morovic.
Thank you.
And now the second speaker is Karen Marr from Buffalo. Is B-mode abnormalities and wall stenosis in the natural history of multiple sclerosis.
Hello, everyone. My talk is on B-mode anomalies.
Do we have sound?
Okay, now it's working. Okay, my talk is B-bone anomalies and IJV stenosis, its criteria 3 in CCSVI, and how it has evolved from 2008 to 2012. What I have done is taking all the published papers that have relevance to criteria 3 in the ultrasound parameters. Okay, I have one disclosure and the rest 2 disclosures for myself. Okay, The original CCSVI criteria from Dr. Zamboni stated high-resolution B-mode evidence of proximal IJV stenosis. This is from Dr. Zamboni's paper dated 2008. And in there it refers to the proximal IJV referred to the inferior end of the IJV. A cross-sectional area of 3 millimeters square was taken as the reference value. From that paper, he determined for relapsing remitting, secondary progressive, primary progressive, with a total of 37% of MS patients had stenosis with this parameter, -3, of less than 3 millimeters squared. Dr. Zamboni's next paper in January of 2009 quoted, absence of high-resolution B-mode proximal IJV stenosis. In this paper, the stenosis was referred to as reducing the CSA as less than or equal to 50% by means of a complete echo Doppler scan in high resolution of B-mode of the CSA of the IJV. In this paper, MS was found in 28% using the criteria of greater or less than 50%. Dr. Hanaki, in March of 2010, presented a paper. He described criteria 3 as B-mode anomalies and or stenosis in the IJVs, where he described flaps, webs, septums, etc., in the lumen of IJVs were considered B-mode anomalies, using 3 millimeters squared for stenosis. At this point in time, it was all one criteria as opposed to what Sandra just presented as a and B parameter. In April 2010, Dr. Simka presented his paper. Where'd it go? Okay. And he used at least 50% stenosis of the proximal IJV. And he described membranous or net-like septa or inverted valves for B-mode anomalies. His paper had 87.1% MS patients presented with them, and for the B-mode anomalies, 58.6%. Dr. Alomari, in April of 2010, presented his paper. He included abnormal valves, ectasia of the carotid bulb causing persistent significant compression of the mid-IJV. He also used 50% narrowing, and he included extensive collateral circulations. His results were as follows. He actually broke them down to the stenosis, 8%, flaps, flaps in the brachial-cephalic vein, ectatic carotid bulb, abnormal valve, and diaphragm membrane. In his subjects, 50 subjects were involved there. Dr. Zamboni, in a paper, July 2010, described his criteria 3 as B-mode anomalies / stenosis of the IJVs. In this paper, he used reference to the 4 millimeter measurement for IJV as a reference. In this paper also, Dr. Zamboni described B-mode anomalies, but in relationship to venography, not to ultrasound. In August of 2010, he presented a paper where he used the CSA of greater than or equal than 50% for his stenosis in the recumbent position only. And his results were 0%, okay, and 0% for controls. Barachini, in January of 2011, used the criteria of CSA greater than or equal to 50% or CSA of less than 3 millimeters. He used both criteria, both measurements, and he also included septums or abnormalities that might reduce or block venous outflow even during inspiration. Okay? His results were with MS patients 16%, with B-mode anomalies it was 24%, and the remaining of his findings. As you can see as we're going along here, every paper is using a different criteria. They're using different measurements. They're taking a different angle to it. So as we go along, you'll see it progresses more and more. And it's very, very hard to take these papers and compare everything. So I'm just trying to get across the point that with the consensus paper, we need to narrow down and define what is abnormal, what is not, and go from there. Mayer, in February of 2011, also decided in the accessible parts of the IJV to be measured. Okay? Before we were doing the lower IJV. Now all of a sudden we're up to measuring the whole accessible part by ultrasound. Okay? Results were 65% in MS patients and 80% in controls. Santonzi, I apologize if I say the names wrong, March 2011, used a parameter of 3 millimeters squared, presence of septums, malformations. His paper, which I used approximation from his paper because there was bar charts, so this is an approximation. His MS patients were 59% and controls 50% using 3 millimeters squared. Okay, Dr. Zavadnov and myself in July of 2011 presented a paper where we described high-resolution B-mode evidence of proximal IJV stenosis and or other B-mode anomalies. We described our B-mode anomalies in our paper, but we introduced, I believe for the first time, we do not measure the lumen. We measure the color flow, the actual flow in the vein, not the lumen of the vein. Our results were MS 64%. We divided into CIS 57% and ONDs, other neurological diseases, 46%, healthy controls 38%. Martyr also used stenosis, was defined as a local CSA reduction of 50% or more in the supine position. She also stated that transverse plane on the grayscale image assuming a circular shape. I'm not sure when I read the paper, I read it a couple times, if you're in transverse plane, why would you assume a circular shape? So I wasn't sure what she was talking about. But again, grayscale imaging, 0 and 0. Barachini did a multi-center study in August of 2011, used CSA of 50% and the 3 millimeters square in the recumbent position, so just in supine. He described it and also described valve incompetence, flow reversal, documented during the Valsalva maneuver. His results were the stenosis, 6.7% in MS patients, and malformation in IJV septum or valve malformation was 11.7 during Valsalva. Oriel, in August of 2011, described venous flow stenosis using a cross-sectional area of 3 millimeters squared, but did not give any individual results, so we're unable to assess that. Bavaria, in August of 2011, a large study of 560 exams. He introduced valve leaflets that work while orientated in an unusual manner, as a definition. He also included caliper reduction of over 70% of the normal lumen as his stenosis measurement. And his results were 87.5% and 67.5% for the B mode. Zvagalis, in September of 2011, used high-resolution B-mode evidence of proximal IJV stenosis. His results were no evidence of stenosis, but his paper did not say what value he used for stenosis. Radek, introduced in September of 2011, put a different twist on things. Introduced stenosis is a segment of segmental stenosis, and if it's 2.5 millimeters, during Valsalva maneuver, okay? He also talked about the IJV confluent stenosis with pre-stenotic dilatation and increased pre-stenotic flow, which if increased in-site stenotic flow was greater than 130 centimeters per second. And again, he described the abnormal valves. His results were stenosis of 39% in MS, in controls 21.6. But when he included the Doppler information, it changed to MS patients at 42% for stenosis, and controls dropped down to 8.1% stenosis. His B-mode anomalies were 43% for MS and 45.9% for controls. Dope, in November of 2011, he used a local CSA reduction of greater than or less than 50 degrees. He had 3% results in 40 patients studied. Bastianello did a multi-center study on this one. They used B-mode evidence for stenosis, malformed valve, annulus, septums, with no definition of stenosis, I think because it was a multi-center study. But for criteria 3, you'll see through the 6 centers, there's a high percentage of positive findings with an average of 80%. And this was using 710 MS subjects. What was interesting about this 6-center study was that 98 patients were negative for CCSVI. Out of the 98 patients, 70 of the 98 patients had one positive criterion, and 33% of the 70 were positive for criterion 3. which Bastianello decided was because criteria 3 is less operator dependent, so it's easier to diagnose. Zamboni in December of 2011 with the ISNVD faculty, as we saw with Sandra, put out a new protocol for criterion 3. They separated into an A and B using 3 millimeter square as the definition for stenosis. I think, as you can see, for all the studies that were done, this was desperately needed. We needed something consistent for all the studies. Intraluminal defects were described as web septum malformed valves combined with hemodynamic changes, okay, and mode investigation of leaflets, which we've all heard from Sandra's study. The ISNVD also, Dr. Zamboni also described the abnormalities as flap, septum, annulus, immobile leaflets. Immobility limited to one of the two leaflets, double channels, anomalous orientation of the valve leaflets, examples as inverted position of the leaflets, leaflets positioned on the lateral side of the jugular wall, truncular lesions resulting in aplasia, hypoplasia, or hyperplasia. Now we come to Dolik and all from BNAC, our center, in January of 2012. We just published a study of intra and extraluminal venous anomalies. This was a subset of our CTVD study where we took 150 or 213 patients, 150 with MS and 63 control subjects. And we re-looked at these patients and we divided them into 3 categories, okay? Intraluminal, meaning inside the vessel wall, extraluminal, outside, and functional abnormalities. So our intraluminal structures included webs, flaps, septums, membranes, and malformed valves. As you can see here, flap, septums, and membranes. Our extraluminal structures were stenosis and annulus. The functional, this was in our study, it's not related to my talk, but I just wanted you to be aware of, is reflux, bidirectional flow, non-compliant, and no flow. Non-compliant for us is, you have to remember the veins have more use than just transporting blood to the heart. It also acts as a reservoir. All veins distend and contract as needed. If they need to hold blood, they're a reservoir, so they extend. So when a vein is not compliant, it stays the same shape, whether they're breathing in or out, they're doing a Valsalva. If it stays the same shape, it's not being compliant. There's something wrong with the vein wall at that point. So it's a functional study when you're looking at it. You're not just taking pictures when you're doing your ultrasound. You're looking at the function of the vein also. So when you see a vein not reacting, the patient's breathing, and it's not reacting, you just ask them to breathe in and out a little bit deeper so you can see that wall moving, because if it's not moving, there's definitely something wrong with the vein wall. Okay. Now, for the results of our study for intraluminal, I'm just going to go over the general. You can read these numbers on your own. MS was 68%, healthy controls 49.2%, p-value of 0.008. As the disease progressed, for non-progressive and progressive, you can see how it also increases from 64.4% to 76.1%. For extraluminal structures, healthy controls 11%, MS 22%, p-value of 0.044. Again, the MS non-progressive and progressive was 16.3 and 34.8%, a p-value of 0.01. So total functional was 33 for healthy controls, 54.7 for MS. Progressive went from 52.9 and 48.7 positive for total function. Okay, now we have structural and functional. There's a summary of the two we just discussed. Now all that rolls into, we have all these findings. And where are we going? Everybody talks about a gold standard. To me, a gold standard is when you do an autopsy and you find out exactly what's going on there. That's your gold standard right now, and that's what we have to compare. Well, the Cleveland Clinic presented at ECTRIMS in 2011 their preliminary findings of their anatomical and histological studies. They harvested bilateral internal jugular subclavian brachiocephalic and azygous veins, and they did it on 7 deceased MS patients, 6 deceased non-MS patients, and these were their results. Stenosis, 4 out of the 7 patients MS patients had stenosis, 3 of 6 of the controls had stenosis. The intraluminal defects, 5 of 7 and 1 of 6. Okay? They used the 50% reduction for stenosis. Okay? Intraluminal defects, valvular intraluminal abnormalities. Now, if you take those studies and you compare it to our study, what was done, your intraluminal defects, you think at first, oh, this is great. MS, 71.4%. MS, we had 68%. Very good, because they're comparing what we were comparing. So we're comparing apples to apples here. We're actually looking at a study, and we're comparing the same thing. So we're getting somewhere. We're moving forward here. Now we come to stenosis. These do not compare very good. 4 to 7, 57%. We had 22% for our 150, and they had controls 3 out of 60, which is 50%. We only had 11%. But when you look at how they defined it, they used the 50% reduction in the same vein. Okay? We used the 3 millimeters. Okay? So we are not comparing apples to apples. We're comparing apples to pears. And I apologize, I couldn't find an orange for Florida. But we're not comparing the same thing, and we have to get on board and compare things the same way. There was another study, postmortem study of 2 cases done by Barachini in April of 2008, and stated that there was stenosis in 2 patients. These patients, the study revealed IJV with ectasia and congestion of the intracranial veins, but there was no definition in the paper of the stenosis. So we couldn't compare anything there. So where does all this lead us? Long talk here. Quantitative ultrasound measurement for stenosis. We have now come up with our consensus from last year of using the 3 millimeters squared as a CSA measurement for the diagnosis of stenosis, which according to all studies done, basically the studies that show the numbers, and we'll have to find out with our pathology how that compares also. But I think we're on to a good start here. This is a picture of, right here is the jugular. It's very small. Okay. But does the measurement of the CSA or stenotic area need to be measured as a flow measurement area or as a lumen? Here you measure the lumen. Now you just heard from our pathology studies that they've proven that there's intraluminal defects. There's flaps, there's membranes, there's septums. Why would you measure a lumen? Because your ultrasound machine might not discern where this flap or septum is. So you need to measure it. This is the same jugular, by the way. You need to measure just the flow. The flow is what you're measuring. That's what we need to know. We don't need to know what the measurement of the lumen is. We need to know what the measurement of the actual flow is, because your ultrasound machine might not see that septum membrane in there causing no flow on the other side. And that septum could be long enough and attached to the opposite side so there's no flow there. If you watch it long enough and you reduce your PRF, you might see it reverting back up for bidirectional flow. Add quantitative data to further define stenosis. So we need to add our velocities, we need to add our volumes and see what that gives us. As you saw in the other paper, it increased the value of CSC SVI, so maybe we need to do these studies and somehow do them, correlate them before everybody goes out, does all these studies. We come back like we are now, and everybody's gone off and done them in different ways, so I'd like to see this weekend if we could get a consensus on how we do these measurements so everyone's on board with the same way. Do we consider the whole length of the IJV for stenosis? Now, meaning the whole length is what ultrasound can see. If you look at ultrasound, if you look at runoffs of angiograms for carotid patients that had angiograms for some other reason, or for artery reason, and you do a runoff, you will see that it's normal for the IJV to be narrower above the facial vein entry. Your facial vein entry is coming in, it's adding more flow, so it's widening out. It's got to widen out. It's adding more flow, so it's just normal. It's going to be wider. So if you took a measurement below the facial vein entry and a measurement above it, there is going to be a difference. So we need to consider where we measure and what we're considering. Again, do we measure from the facial vein entry to the subclavian for stenosis evaluation? We need to discuss that. And what defines an abnormal or malformed valve? Well, we have lots to talk about for valves, as we've heard. We have inverted leaflets, inverted valves. We have remnant leaflets. We have tethered valves, calcified leaflet, calcified valves, duplicate valves, stenotic valves, agenesis of the valve. And stenotic valves I haven't heard anybody talk about. But I want to just mention, when you have a tethered valve and you have the leaf coming over and it's attached by a little septum, that little area makes a big difference. And if you're doing a Valsalva maneuver to try and see, you're measuring the opposite effect. You're having the flow come from the brain coming down, and it's going into this little area the valve won't open up enough. So you're having stenosis there. You do Valsalva, all you're measuring is whether the blood flow is coming up from the subclavian. We need to also measure it as it's coming down, which is the most important. And all this just shows dysdynamic valve for all these definitions. And what is normal, what is abnormal for these? That's why we're here today, to figure it out. And thank you for your attention.
Thank you. The presentation is open for discussion.
While we're waiting for questions, I have a couple of quick questions. First, how many of these papers that you've quoted are still in abstracts? My sense is that most of them are still meeting abstracts, correct?
Correct.
So they haven't undergone full peer review. So we still have...
No.
No.
They're all published.
These are all fully published
All
papers?
published, oh yes, definitely.
Okay, great. That was my one question. You quoted a number. I mean, my impression is that this is the Tower of Babel. That was what you basically said, that almost every paper has a different language. It isn't comparable.
Right, exactly. And we need to all get on board so we can compare.
And you, Nicolaides?
Thank you for a very wonderful review, and thank you for giving us some food for thought at the end of your presentation. I have a question on the early papers you presented, 2011 and so on, where you showed there was no difference between normal controls and patients with multiple sclerosis, and you were referring to the presence or absence of jugular vein stenosis. Mm-hmm. I can visualize some people doing only M-mode in the patient lying down and finding no difference. And if they didn't do a Valsalva to show they cannot open that lesion or they can open that lesion, they cannot make the correct inference. And my question comes back to this. You've read those papers in great detail. I haven't yet. Can you tell us in depth if these discrepancies could be to poor methodology, that they just looked and they didn't test the way we should, they didn't look for corroborative evidence of high velocities or inability of the Valsalva to open those lumens, or based on your knowledge, are those true observations that we can rely on? What I'm asking you, an in-depth judgment of those papers to save us going back to read them all and make our own judgment. Perhaps we should all go and read them.
Right, read them in detail. When I read the papers, I actually had to read a lot of the papers 2 and 3 times because it's more what was missing from the paper. They did not describe in detail more of exactly what they did in their methodology. It was more in general terms, and I think that's the problem. I just picked out what I noticed. Like some of them did Valsalva and only Valsalva. They didn't assess the valve without Valsalva. Velocities, not too many used velocities because it wasn't in the protocol that was written, so it was just in our later papers that now we're seeing more about velocities. And nothing about volumes, mind you. We need volumes too.
Nikos?
Actually, I enjoy very much your excellent presentation. Some notice, maybe when we use so low PRF, then we have overlapping overriding of the color. So about the measurement of cross-sectional area, I think, to my opinion, first we have to use, of course, color to see if there is defect, intraluminary defect or something like this, and then we have to measure in beam mode imaging, because always we have the overlapping of the color.
But what if your color doesn't completely fill your lumen?
No, the question is, if you should have, for example, different color because you have bidirectional flow, or no color at all because you have blocked flow.
Right.
What is your methodology? If you add 3-4 section of your vessel with different color, what's the true color you measure? What is the area you measure? If you have red, blue, what is your cross-sectional area measuring that in that case?
I wouldn't measure the cross-sectional area until I found out why I have that flow doing that. It's a functional study. I think that's the biggest problem with most of the papers. They're taking the ultrasound, they're taking pictures and trying to come up with an answer. It's a functional study. You have to watch the vein. You have to watch how the vein reacts. A lot of times you get reflux just because of another tributary vein is entering, and it's entering at a cephalic direction. So it's going to be, you're going to have the reflux. I'm not sure right now if that's causing a problem, but that's the source of the reflux. Right now we're just saying, oh, there's reflux, but we're not looking at the source of the reflux, and we need to do that also. Everybody's just looking at, oh, the valves are causing it. No, I think sometimes when you have these thyroid veins that are huge coming in, mind you, they're huge because they're collateral, they're coming in at an upper angle, and they're shooting in to a slow-flowing vessel, okay? The flow is very slow coming down because most of the flow is going through the collaterals. As it shoots in and up, it's causing the reflux up.
When you should have bidirectional flow, so red and blue, for example, do you measure both the area, red and blue, just the red, just the blue? What do you suggest in that case?
I would measure the blue, but you have to be very sure on what you're doing. Yeah.
I think that it's not a reliable measurement.
But if you're measuring the red and...
It's a little early.
Right.
To shift the criteria to say that just color should be measured for the very reasons that you're arguing, because this is a moving target as to what to measure. I mean, if there are two things here. There's one which is to create uniformity of measurement, and the other one is not to screen out interesting information, which is these very potent observations that you're making. But the things that you're reading can't be put into this bucket yet. So we just need to keep collecting these methodically and correlate them with these other measurements as you're doing, but not necessarily move the ship. What's interesting to me, though, is that if you're going to look at that color and you have incomplete filling, then that should be the signal to look for the structural abnormality and still measure the vessel diameter, but not throw away the vessel diameter. That's reproducible by almost every operator. A vessel diameter, everybody can measure that. And at the same time, one other comment.
Okay, so if you had no flow.
Well, that's a binary observation, though. No flow, blockage, that's a binary observation.
No, you have, like my image showed, you have flow coming down, but you don't have flow in the opposite direction, and it's not filling the lumen, so you just have your flow coming down. So it's more like a stenotic area caused by a membrane.
So I think what we got from this when I made sort of tongue-in-cheek the Tower of Babel is the idea that there's still some very early front-end observations to be made. It's not going to be solved from the podium, but we know less than we know.
Right.
And it's a right place for a pictorial essay of all of these observations so that you know, people can consider what to measure. So,
True.
Very comprehensive. Thank you.
Oh, hi.
Very short comment.
Very short.
0.3 centimeters is not 3 square millimeters, it's 30. So you should change it on your presentation next time.
Say that again.
0.3 square centimeters
Oh.
is not 3 but 30.
Oh, did I have it wrong? Okay.
Huh? Mathematics.
Thank you. We move to the next presentation. Is Angela Legace from Barrie, Canada, and the diagnostic value of CCSVI criteria.
See that? I'm special. Where's my clicker? Oh, mine's not on here. I'm also very special. See that? Hang on. Maybe these guys know? Okay, so my presentation is not on here, so I'm going to be facing this way, and I don't want to put my back to you gentlemen, so I'm going to sort of go like this. I think this is what I'm supposed to use, yes? No, you're not helping me, it's okay. Oh, it is, look. Obviously, disclosures, I don't have anything to disclose. I'm going to keep mine really quick, as I know we're behind, and Sandra had pretty much covered so much of what I was going to say. So we'll just go from there. Basically, protocol, again, review of the protocol from Dr. Zamboni. Everybody's sort of covered that just in the last 10 minutes, so that's not something I'm going to waste any more time on. Another thing I just wanted to touch on, and this has to do with the diagnostic value of the criteria, is the positive threshold. And when I say that, what I mean is we don't measure with ultrasound diameter reduction in a percentage, whereas I know in angiogram they do. This is becoming quite a challenge with my patients that come into me. I've scanned, well, probably close to 4,500 patients, so I've got a very large sample volume. And a lot of them sort of say to me, what is my percentage of, blockage or stenosis? And we don't measure that. Some patients have the criterion been positive for CCSVI and have gone to other facilities and treatment centers to have it done, at which time they get on the table and they don't actually perform, saying that they don't meet the criteria. And I've spoken actually to Dr. Zamboni himself and another physician about that, and to try to figure out why that is and what is the percentage. We're not sure if there's a percentage, if it, let's say, arbitrarily 30%, if they have 30% or less, do we see it on ultrasound? Don't we? I don't know. It's just something else that we need to kind of maybe look into or figure out a way to nail that down. Those are just a couple of things that we've come across. As far as the diagnostic value of each of the criteria, it's there. We see it every day in these MS patients. So again, this is just an example of reflux in the jugular veins. Some of these are supposed to move, and I don't know if they're going to, so you'll have to bear with me. The second criterion, again, the deep cerebral veins. This is an example without the QDP application. On inspiration, there's a spectral waveform, and on expiration, there is not. Again, value to this one as well, as it is supposed to be monodirectional, and clearly on this example, it's not. I know there are some centers that have sort of dropped this criterion or certainly don't use it and go with a 4 out of 4 as opposed to a 4 out of 5 scoring system. Again, B-mode abnormalities. Oh, look, it moves. That's exciting. Okay, so they figured it out. So there's you see the arrows pointing to that that valve leaflet there. That it's moving, but it has absolutely no function. So again, a B-mode abnormality. Karen just covered a huge area there, so we'll just click here and keep going. Here's an example of a block jugular vein. The PRF is low, but you can still see it's not filling, and it's not actually responding to any respiratory phase as well. So again, very, very valid. You can't mistake in that. The cross-sectional area measurements, again, we've covered this so much today. I think, again, it is consistency. It is knowing your anatomy. I think the original J2 area should be where it's taken. You have to measure the whole lumen because you don't know what's going on the other side. If the lumen is there, that's what you have to do that. It just makes the most sense. It's the most consistent thing to do. Again, you need the patient cooperation with the respiration. A lot of MS patients have a difficult time breathing, so especially nasal. So you have to sort of watch that kind of thing. Another reason why the ultrasound as well is so important, and the value of it is post-angioplasty, when we're seeing the complications that happen there. This is an example of thrombosis. There's no stent here. This is just a thrombosed IJ after an angioplasty. I believe this was about between the when they first got back, so about 6 weeks in to post-angio coming to see us. The second, I have a stenting on the left side. That is a patent stent in transverse, and on the right side is completely thrombosed there. So again, very valuable. You can't, this is what we rely on every day, being a vascular sonographer and working for a vascular surgeon. We see pretty much everything there is to see, and when you're looking for sort of thrombosis and DBT, it's very valuable. So the last thing is restenosis, of course, patients coming in and presenting again with reflux. So I've just put a couple pictures up there for that. And, of course, limitations, as usual, patient positioning. I covered this in my previous talk, but I don't know how many were there or not there. So patient positioning, not being able to perhaps go in the supine position if they're in wheelchairs and are disabled, that sort of thing. And, again, respiration. Not all patients are good breathers, so those things depend on that. But that's it. Fast.
Thank you, Angela. Are there any questions from the audience? So it seems very clear. No?
Oh, I thought I was going to win.
An observation. I'm Dr. Schulte from Argentina. Which criterion do you use for restenosis? Because normally the valves, they always have a reflux because they are destroyed or open.
Right. I do the whole entire exam from A to Z again, and we see if there's any sort of, I mean, because the 2 out of the 5 criteria need to be met anyway, I do everything from A to Z, even post-angioplasty. So I do the full assessment.
But which criteria do you use?
I don't.
The same.
What do you use for restenosis? If I may perhaps rephrase it, are you saying what is the most compelling criteria? What's the most important one to you when they return after angioplasty? Is that the question?
Yes.
Yes. What's the most valuable ultrasound criteria for someone who returns with possible post-angioplasty restenosis?
Well, I guess, reflux and, reflux and usually the valve assessment to see if there's still any obstructions that way. And Sandy might want to jump up and say something.
I would change that because what we do is we do the ultrasound before. We try and get an ultrasound done after and follow with the ultrasound after. But on the follow-up studies, if you look at all the criteria, we're still using the original Zamboni criteria because we've got studies underway that started with that criteria. And I'm hesitant to change mid-study because I think that's going to invalidate what we're doing. So you have to give us a little bit of latitude. But when we see them come back, the most compelling thing is thrombosis, right? If it's thrombosed, it is really simple, right? Restenosis is a little bit harder. If study number 1 says you got 3 of 5 criteria, study number 1 post says you got 0 of 5 criteria, study number 2 says now you've got 3 of 5 criteria again. It isn't any individual specific criteria that says you have return of CCSVI. It's the cumulative criteria that we're using. If I was to say which one I put the most credence on, I think it's the delta surface area. Because if it doesn't change, now you've got a relatively immobile valve and it's non-compliant, and I think that gives you a lot of information. If you look at the valves, typically the valves are destroyed, but that doesn't tell you about compliance. It just tells you that the valve is giving you reflux. What I look for then is the lack of compliance.
And that emphasizes what Ms. Morrow was emphasizing as well. So, great. Thank you very much.
Thank you very much.
Thanks. What do we do with this?
We're going to bring up the next speaker, Dr. Erika Menegatti from Italy, who's going to talk to us about does the thoracic pump influence cerebral venous return?
I already, yeah.
Excellent. Everybody.
Thank you. What happened, Angela? I am.
See?
Yeah. Thank you, Angela.
We can leave now. They can take care of themselves.
Okay. Good afternoon, everybody. Many thanks to the organization for this kind invitation. And the study that I will present is completely physiology study in which we work in order to give an answer at these important questions. Does a thoracic pump influence the cerebral venous return? And also in order to give an answer at the previous discussion about the velocity and the needs to have more data coming from the physiology on that field. So, as well known, how the blood leaves the brain through 3 different important mechanisms. The first one is the cardiac output, or the disatergo. The second one is the activation of the thoracic pump, or the so-called bisafronte. And finally, we have an hydrostatic gradient exclusively in upright position that favors the outflow from the parenchymal veins to the veins of the base of the neck. Whereas the thoracic pump is particularly active. Sorry, I don't.
It progressed just in the.
Okay. Thank you. Thank you. So, whereas the thoracic pump is particularly active when the subject is in supine position and there is no gravitational gradient that favors the return. The pump acts increasing the negative interthoracic pressure from minus 3 centimeter of water during the expiration till minus 8 centimeter of water during the deep inspiration. So on this basis, our purpose is to assess the hemodynamic effect induced by the thoracic pump on the intra- and extracranial veins of the cerebral venous system on healthy volunteers. For this study, we recruited 44 healthy volunteers among the residents, the PhD students, the students in medicine of our university, with a male-female ratio of 21 out of 23, with a mean age of 27, with a standard deviation of 5. This protocol consists in two main parts. The first one completely done by the pneumology team, and the second part regarding the hemodynamic assessment performed by our vascular team in the Doppler lab. Regarding the assessment of slow vital capacity, that technician performed a spirometry according to the international guideline, repeating the procedure 3 times and choosing the best value of vital capacity. Subsequently, the action of the thoracic pump has been standardized at the value of 70% of individual vital capacity, and to do this, we use an instrument originally designed to exercise the respiratory muscle. This is a portable instrument connected to a calibrated bag, which patient fully filled and emptied during the hemodynamic evaluation. Right after the pneumology assessment, the subject were sent to the Doppler lab, and we start the protocol from the intracranial cerebral venous system, which is composed by 2 different networks, the parenchymal vein that we name N3 and the sinus of the dura mater that we name N2. And we choose the Rosenthal vein as a representative of network number 3 and straight sinus as a representative of network number 2. And the window of insonation was the transtemporal bone window for both venous segments. We measured several hemodynamic parameters: the peak velocity, the time average velocity, the vein area, and the flow in millimeter per minute. All the measurements were obtained in supine position, and the data were collected at rest and after activation of the thoracic pump. Finally, we assess the extracranial cerebral venous system, choosing the internal jugular vein as a representative of this venous network, because it's the main outflow pathway when the subject is in supine position, and we name this network number 1. We subdivided the jugular vein in the 3 different points of measurement as a consensus states. So we measured J1 above the carotid bifurcation, J2 at the level of the thyroid gland, J1 at the level of the junction. Once again, we measured the same hemodynamics parameter in supine position at rest and after activation of the thoracic pump. What about our result? The table over there shows the value of peak velocity measured in all 3 venous segments, but what we found was a significant increase of peak velocity limited of the extracranial compartment. So the peak velocity measured on the jugular vein, the peak velocity measured on the jugular vein increased from 52.8 at rest till 72.5 during the activation of the thoracic pump. Another important finding was the trace recorded on this different segment, as the picture shows. The trace increased the effect of the modulation approaching to the chest. So in the upper part of the figure, it clearly appears as the trace measured in the Rosenthal vein is completely flat,
less in the straight sinus, and whereas heavily modulated in the jugular vein. Also, the other hemodynamic parameter, like TAV and Q value, confirm this behavior. This table shows how this value increase from the jugular foramen to the base of the neck. And also, we give you percentage variation, and what we interesting to underline is the variation of more than 80% of the flow measured during the deep inspiration. So this figure shows this behavior from the modulation increased as the point of measurement is closer to the chest, as well as during the deep inspiration. So finally, we found a correlation between the intra and extracranial hemodynamics. So this graph shows as a value of Q flow recorded on the straight sinus linearly increase with the TAV value measured on the jugular vein. But this is true only at rest, and the correlation is lost when the subject activates the thoracic pump. So our result opened a new discussion. We wondering why bilaterally we measure a flow greater in J1 than in J3, and the equation of continuity is not satisfied. And the second question is why the flow is increased under breathing, but only limited to the jugular vein, and not variation on the intracranial veins was recorded, and why we lost the correlation during the thoracic pump activation. Well, the anatomy can help us to understand the reason of that. The picture over there shows the jugular tree, which several re-entry points of the collateral, indicated by the arrows. So we measure an increased TAV, an increased velocity on the jugular vein, and by means of the Venturi effect, the collateral emptying into the jugular vein. This collateral drains the face and the neck and impart the intracranial territory through the intra and extracranial anastomosis. Finally, in order to understand better the reason of our results, we developed a lumped model together with our physics department, in which we include also this neck and facial vein that we name network number 4. And when when the thoracic pump is activated, there is a pressure drop on the jugular vein, which in turn leads to an increased flow on that jugular vein. But besides, there is another pressure drop from neck and facial vein to the internal jugular vein. This pressure drop causes an increased flow also in the neck and facial vein, and it's emptying into the jugular vein. On the other end, inside the skull, the pressure doesn't change because the skull prevents from any atmospheric pressure variation. So the only reason that we have an increased flow below J3 point, as the anatomy shows before, is the emptying of the collateral vein into the jugular vein. So these are our take-home messages. Firstly, we question the value of Visa Fronte in ensuring the cerebral venous return. We found a significantly modification of the thoracic pump on flow and velocity, but limited to the extracranial vein, comprising also the neck and facial vein, the collaterals, and no significant variation were recorded intracranially. On the other hand, the vein behind the orbit could be influenced by this respiratory modulation, but in the present study was not measured. And finally, the flow on the J1 is increased respect to J3, either at rest and after activation of the thoracic pump, and this suggests us several re-entry points of blood toward the jugular coming from the neck and facial vein. So many thanks to our Department of Physics, as well as the Biomedical Sports Studies Center for the pneumology evaluation, and of course the Vascular Disease Center people. Thank you.
Thank you, Dr. Menegatti. The paper's open for comments. Any questions or observations? Well, as you're coming up, Karen, just perhaps a question of ignorance as a new area to me. The time between the breathing exercises and the measurements was how long again?
We measured 30 minutes. We recorded a trace during the respiration of 30 minutes.
I'm sorry, were you measuring?
30 seconds, sorry, seconds.
So
30 seconds of
30
exercise.
And then immediate measurements there afterwards. So no time in between.
No time in between.
All right.
That was one of my questions. The other question was, did you check the valve, whether the valves were competent before you did this?
No, we don't check the competence of the valve, but we measure a flow just above the valve, and so we have to take into account the differences between the subject in order to the presence or not of the valve.
So these are all normal patients. So one of the next natural questions will be, is the circulation different or more susceptible to changes in the thoracic pump in patients with abnormal valves or reflux or otherwise? So is that the next stage of your research?
Yes, sure.
You're going to do this in patients with...
Yes.
Excellent.
This is a good set of data because we have normal values calculated in both conditions of measurement at J3, J2, J1 in a large sample of normal people. So this of course is a good basis for understanding better physiology and blood flow velocity as observed by Professor Nicolaides during the beginning of our section. So I think that the value of this paper is also to provide a good reference point of normality.
Thank you very much. Let's go on to our next speaker. Now, very pleased to have Dr. Simka speak to us about a prospective study comparing ultrasound and angiography. Welcome. You need a mic? You need a mic.
Try to speak your mic.
Okay. Oh, okay. This is working. So these are my disclosures. I think I skipped these slides because it's also already said several times. So what is CSVI and the definition given by Paolo Zamboni. Of course, how to diagnose it. Also, these criteria have already been discussed, these new criteria, but unfortunately, all these criteria, previous and new, are only conjecturing, are guessing. And at the moment, we have no good data supporting this criteria. So it was also discussed how to diagnose, how to measure it, and so on and so on. And here's our new prospective study. So it tries to look how reliable are these criteria. So we looked at a group of 58 patients with clinically defined multiple sclerosis. So in total there were 116 internal jugular vein and vertebral veins assessed. performed according to this protocols, these suggestions. We looked at the Sambonis criteria, the new International Society Neurovascular Disease criteria. Of course, we look only at the extracranial criteria, and we skip this intracranial criterion because we have no good equipment to look at these intracranial veins. And as a reference test, we use catheter venography, and we regarded positive venography, pathologic veins, on condition that was at least one of these parameters. So venous outflow slow down, or reverse flow direction, or pre-stenotic dilation of the vein associated with the slow down outflow or reflux, or outflow of the collaterals, no outflow through the vein, hypoplasia or narrowing of the vein associated with any of the above mentioned pathologic flow patterns, or intraluminal structures such as web, septa, and so on, comprising outflow, or complete occlusion of the vein. And unfortunately, you can see that these accuracy parameters were not very good. In terms of sensitivity, these numbers are quite good, but specificity was very low. Also, negative predictive value very low, positive predictive value not very satisfactory. So we are in big trouble, actually. What probably was associated with this very low accuracy of these findings, if we are regarding the catheter venography as a reference test? Firstly, reflux. In our experience, a real reverse of the flow is sometimes it can be found, but it's extremely rare. And most of so-called refluxes represent actually either improper position of the gate of angle or some other artifacts. In our opinion, such things are like a vertical flow or twirls in the valve area should not be interpreted as a real reflux. And which is very important, we found this bidirectional flow both in the veins who were found normal and abnormal during venography. So most likely it is not a pathology by cell. Next problem, stenosis. It was already discussed that actually we are lacking good definition of stenosis. One proposal is a cross-section area which is less than 0.3 square centimeter. But if you are evaluating our patient, we found that actually this parameter should be probably much less, and we found that the threshold should be probably at the level of 8 square millimeters. Another parameter of so-called stenosis is valve. On the left side, you can see that this valve looks normally. Okay. On the right side, you may say it's abnormal. It's a membrane septum or so on. So the left is normal, this is abnormal, but what about this one? For sure, if you have a definition of abnormal or normal valve, some parameters should be given. The other question is whether we can accurately assess these valves using transdermal standard ultrasound. Perhaps IVUS should be used to assess this valve properly. Next parameter, no flow detectable. So, of course, some cases are very obvious, but we found that in many cases the stop of flow, no flow, results from external compression of the vein. And many of these cases are not visible during venography. It's only visible on ultrasound, also it's visible in magnetic resonance venography, but when we inject contrast into the vein, this contrast flows freely. And at the moment, the meaning of such a phenomenon remains unclear, which is also very important at the moment. Safe endovascular treatments of such a stenosis, compression, or whatever you call it, is not available. For sure, angioplasty is not working in this cases because it's simple compression by muscles or other structures, and putting a stent in this area is not very safe. You may expect a high rate of migration of such a stent. Maybe, as it was suggested by Dr. Tucker, his paper was published recently in Medical Hypothesis, there are some so-called standing waves which evoke such a collapse of the vein. For sure, much more research is needed. So no flow. At the left is normal flow, in the middle no flow, and perhaps in the right side you can see this flow is present but it's not effective. Next problem, negative delta cross-section area. So we found that in some cases, okay, it's due to stenosis, pathologic valves, which is a reversal of behavior of these veins, but in many patients this negative delta actually is seen in the healthy vein, and most likely is due to compensatory flow through the only remaining patent vein. So these two sets of criteria are not very reliable. Next, we looked, perhaps squeezing our data, we find something. At that moment, we had more patients, was over 100, so there's 230 internal jugular veins and vertebral veins. We looked at 41 different sonographic variables. So flow direction, presence of reflux, absence of flow, peak flow velocity, presence of interlaminar defects, quotient of maxima and minimal cross-section diameter, so-called pancaking of the vein, cross-section area, delta. We look at these parameters in J1, 2, 3 vertebral veins in supine and upright position. So in total, we have 41 different variables. And we perform multivariate regression analysis of this data, and we found that some data correlated with pathologic venography. It was no flow detected in J1, J2, J3 segments of internal jugular veins, but in the upright position, not in the supine. Also, we found that the peak flow velocity in the upper and the middle segments of the jugular vein, again in the upright position, which was less than 24 centimeters per second, and in the J1, which was lower than 88 centimeters per second, correlated with these abnormalities by means of venography. And in addition, upper segment, the J3, in the supine position, this flow which was less than 24 centimeters per second. Regarding cross-section area, in the upper segment, which is J3, in the supine position, which was less than 8 square millimeters, also correlated to some degree with abnormal venography. But unfortunately, there was a big overlap of these abnormal and normal groups, and this overlap was about 40%, and consequently, even using these parameters, we are unable to create a good set of criteria. So our research is showing a clear gap in the understanding of hemodynamics in this venous territory, and for sure much research is needed. Thank you very much.
And one observation and one question. The observation is, in 2007, I have to convince an ethical committee of something that was considered absolutely crazy: to study with catheter venography and eventually treating patients with multiple sclerosis. In order to convince my IRB, I developed a set of data based on 5 criteria, and the ethical committee required for each of the criteria the reference that was at that time available, and was a screening method. What does it mean? If my point was, if you should have 2 of these abnormalities respect to what was the status of the art of ultrasound of the jugular vein, you have a high probability to find some abnormalities in your catheter venography. So now the question is, how many of your patients with 2 of the criteria proposed showed no stenosis in your catheter venography study? So this is the point. CCSVI ultrasounds, it is a screening method to avoid the possibility to study patients for nothing. So how many of patients with 2 criteria were negative at your catheter venography?
But Paolo, the problem is that we already know that actually the prevalence of these venographic abnormalities in these patients is very, very high. So if you take
very, very high, how many with 2 positive were negative?
But regarding the prevalence of venographic abnormalities is over 90%. With any set of criteria, you have
so
very...
it does work.
Not necessary.
Okay. Professor Nicolaides.
I have a similar question. In the 116 jugular veins you studied, of the 58 patients, how many were normal and how many were abnormal? 116.
So in this set there was only 2 patients with normal both veins.
Thank you. No.
Huh?
116. You did both sides. Out of 116 jugular veins you have studied,
I see. Okay.
how many were normal?
It was about 30%.
30%.
About.
Yes. My worry is that sensitivity and specificity depends on the prevalence of the disease. And it's very difficult to talk about sensitivity and specificity with such a high prevalence of disease. The only way to do sensitivity and specificity properly is to have 50 normal and 50 abnormal and do the same test in all of them with an objective measurement that tells you whether there is disease or no disease. And projecting my thinking, we have to rely on the studies of people that do probably ultrasound, and perhaps IVAS is a question you posed, but they have to have in their group a lot of people that are normal, because it's the only way to find how many positive predictors we have and how many are negative predictors.
Exactly, but the problem is to find this high number of normals in these patients. So the best way would be to assess not patients, but healthy controls, but how to get the approval from the committee to look at it.
The problem is to do a proper study.
We're talking about type 1 and type 2 errors. Yeah.
Yeah, I echo completely what Dr. Nicolaides said. I mean, when we are talking about sensitivity and specificity, we need to have healthy controls. I mean, you can't, and I mean, that's kind of really necessary. And second thing, you said they are very bad values, but, all your sensitivity and specificity was around between 75 to 80%. That's even better than what we find between MS patients and healthy controls. So, to properly say, hey, in 80% of the cases, I'm finding something that's sensitive to detect it and too specific to be exactly, I don't think it's bad. I really don't think it's bad. I think that, yes, there are always 20% of patients that need to be, that will not be diagnosed properly, but it's a very good screening tool. And then, as we will be speaking later, clearly when MRI is incorporated, you can probably achieve much better specificity, although you are going to decrease some sensitivity. So I'm saying that in properly trained hands, 70 to 80% sensitivity and specificity is really a good result. Now, if you would go and see what's going on in the literature, if everybody would be convinced that it's 70 or 80% sensitivity and specificity, that would be amazing. But we have, so many papers saying that it's zero. So you understand my point here.
Yes, but on the other hand, there are some colleagues who they are saying, we are performing only venography and we are finding over 90%. Why to do sonography or other non-invasive tests when we are better with our catheter venography alone?
Yeah, because they didn't do the healthy controls. That's why they are finding 90%.
Well, but we're also throwing in the fact that the gold standard, which is the venogram, may not be 24-karat gold.
Yes,
as
you
well.
are exactly right.
There are a lot of issues here that are polluting.
Actually, this paper is accepted to be published, and this is discussed. Perhaps this venography is not reliable and is not gold.
Maybe the last comment, yes.
Sorry. Actually, Marianne, all of us, we agreed to revise some criteria, but now I think we put it out, all these criteria. I have an objection. During your talk, you said that your device, your ultrasound device, it is not so good. I believe with high-end devices, with sophisticated devices, and with linear probe, more than 10 megahertz, we can see everything in the jugular vein, everything. Also the stagnation of the blood flow. So, absolutely absolutely disagree with you in this sector. Okay?
But if you have equipment with better quality, perhaps this visualization of the valves, septums could be better. But flow velocity, it should be the same, irrespective of the equipment. Also diameter, this delta cross-section area, it will be the same with any sonographic machine. It will not much change, irrespective of the parameters of the machine. And we found this delta cross-section area was
let's keep
no,
short,
but it was compared.
Because it's being recorded.
Yes, this examination was done before venography, so it is perfectly blinded.
I think the whole discussion really speaks well to the importance of multimodal assessment, including MRI, because I think that's going to take a whole lot of the variables out and will help us decide what is real and what isn't real in terms of diagnostic criteria as well as venographic criteria.
I think the closing words were to Dr. McDonald for that paper. So with all due respect, Karen, if you hold it, we may well have time for discussion afterwards. Certainly we need to find something that is broadly applicable, and it may be that we've got to solve it with multiples. But let's move on to welcome Dr. Morovich back for the closing paper here, a hemodynamic model for quantification of cerebral venous return.
Yes, I got one.
Let's get the slides on the screen.
Okay, I'm just opening it. Okay, well, hello again. You're stuck with me for another while. I want to present to you something that we worked on recently, and actually it's still ongoing research, a hemodynamic model for quantification of cerebral venous return. Now, just a quick introduction that I think all know that the venous outflow depends firstly on arterial inflow, on the cerebrospinal fluid circulation, and on venous drainage. Human studies through time have shown that humans have two main outflow patterns. In the supine position, it is the internal jugular vein, while in the sitting or the upright position, it is the vertebral veins. This was nicely shown by Gisolf's paper in 2004. And just to give you a few numbers, you can see how the numbers really change from supine being the 700 milliliters per minute to a sitting position when it's 70. And also the vertebral flow changes from 40 to 210. And also on the right side, you can see the cross-sectional area dropping as the person is moved from the supine to an upright position. In 2004, there was Depp's paper on how does the blood leave the brain. They had 50 subjects. It was an ultrasound study of internal jugular veins and the vertebral veins, but the study was done in the supine position only and at J3 point. What they found out was that people could be subgrouped into three types of venous drainage. So they said there was a jugular drainer that drained 72% of blood through the internal jugular vein as a type 1. They had 72% of people, meaning that more than 2/3 of the cerebral blood flow went out through the jugular veins. The second type was the neck drainer, draining between 1/3 and 2/3 of the flow. And the third type, the non-jugular spinal drainer, draining less than 1/3 of the flow through the internal jugular veins. These are their results. The total arterial inflow was 752. The venous outflow was around 670, divided into internal jugular veins 630 and the vertebral veins 36. This is just, I'm referring to this type 1, type 2, and type 3 because I will come back to it after comparing our results to this paper to show you some interesting things. So maybe I don't need to go into detail with the numbers, but I will go on as is. So this mismatch between the quantification of incoming and outcoming blood volumes that were calculated by previous modeling attempts created a need for an improved hemodynamic model to be made. In addition, we feel that this was the amount of blood that was flowing through the collaterals. Our aim was to build a hemodynamic model that would best describe quantitatively the circulatory pattern of the head and the neck. Our study, this what I will present, is on 5 healthy volunteers, 3 males and 2 females. We measured the inflow and the outflow of the intracranial and extracranial blood. Measurements were taken on both sides in both positions, meaning supine and sitting. It was a 4-second period and 4 main arterial and venous points. After all this, lumped modeling was performed to understand the venous circulatory pathway. Our points of assessment were 4 main arterial points. It was the common carotid artery, internal carotid artery, external carotid artery, and vertebral artery, so on both sides. And we had 4 main venous measurement points: the internal jugular vein at points J1, J2, and J3, and the vertebral vein. So as I said, measurements were taken in both positions and both sides. What we assessed the time average velocity, the cross-sectional area, and the flow volume. And what we found was really interesting is that the arterial inflow was equal to the arterial outflow, which, if you remember, was different from the studies done before. This is the lump model made by our physicists, so maybe just to show you, the top red area is what I mentioned, the 4 main arterial inflow points. On the left is the vertebral artery, then it's the common carotid, which divides into the external carotid and the internal carotid. As we divided it, is the ICC is the intracranial compartment, which gets blood from the vertebral artery and the internal carotid, and the extracranial compartment, which gets blood from the external carotid artery. So basically, down on the bottom, you can see where we measured the outflow. It was the vertebral veins, the internal jugular vein, and if you follow it up, there's 3 points on both sides, and in the middle is the collateral network. These are our results for the 5 people. We found a significant difference between the blood flow volume between the J3 point, which is the most distal part of the internal jugular vein, and the J1 point, which is the most proximal part. As you can see the numbers, the J3 was around 385, and the J1 was 732. The difference in blood volumes between these 2 points quantitatively corresponded to the blood volume incoming through the external carotid artery. And this amount of blood re-enters the internal jugular vein and the vertebral veins on each side. Our results did not significantly change with the change of position. I will present you 3 cases of 5. So this is our volunteer number 1. You can see his total inflow was measured as 875 and the total outflow as 873. And since inflow and outflow were very comparable, we assumed that all main vessels involved were measured. So I just want to point out here that the total inflow was the common carotid artery, meaning the internal and the external, and the vertebral artery, because you might see a difference in numbers later. So, okay. So basically the total, the cerebral blood flow was about 500, and 75% of this blood flow was drained through the internal jugular vein at level J3 and the vertebral veins. So there was a flow difference of about 500 milliliters, and we think it accounted for the remaining 25% of the cerebral blood flow and the flow coming up through the external carotid artery. Since the flow difference between points J1 and J3 was out of our confidence interval, we explained it through the collateral pathway coming in through the internal jugular vein between the point J3 and point J1. So basically, if you remember the classification from earlier, this subject would correspond to a type 1 drainer, meaning that jugular drainer, he is a jugular drainer even if he was measured only at J3 point. Then we put the patient to a sitting position, and his inflow was about 860, and the total outflow was a little bit less than 800. Again, we had a big difference in points J1 and J3. They were out of our confidence interval, so we could explain it by the collateral pathway coming in between these 2 points. The cross-sectional area was as expected. It dropped on both sides when the patient moved from supine to a sitting position. The vertebral veins blood flow was around 10% of cerebral blood flow in the supine position, and it became close to 90% in the sitting position. This also corresponds to the paper of Gisolf. The flow of the internal jugular veins at level J3 was around 130 milliliters per minute, and it was only 20% of the cerebral blood flow. So this showed that this person was drained by the internal jugular veins in supine position and by the vertebral veins in the sitting position. But then, in the sitting position, we noticed that this subject was not a complete vertebral drainer, as it would seem if we had only measured him at the point of J3. Because in J3, there was a flow of 130 milliliters per minute. Vertebral veins were a little more than 370. And according to this, he would be a type 3 drainer. But then at J1 point, we again had another 365 milliliters per minute, making it 78% of his outflow. So he actually became, again, a type 1, a jugular drainer. Then we have our volunteer number 2, with a total inflow of around 1,000 and also the total outflow around 1,000 milliliters per minute. Again, the inflow and the outflow are comparable, so we can say that all main vessels were measured. The cerebral blood flow of this volunteer was around 680 milliliters per minute, and he drained 79% of cerebral blood flow through the internal jugular vein at J3 point and the vertebral veins. Again, we had a difference of about 507 milliliters per minute between our point J1 and point J2. And when it was calculated, it showed that it was the remaining 21% of the cerebral blood flow and the external carotid of almost 300 milliliters per minute. So again, we had these two values were out of our confidence interval, so we explained it by the collateral pathway between these 2 points. So this subject would correspond to a type 2 drainer because he drained between 1/3 and 2/3 of cerebral blood flow through the internal jugular veins, making him a neck drainer if he was measured at J3 point. But then again, if you compare the two values between J3 and J1, we can see that J3 was about 350, but when he was measured also in J1 point, it was the flow of 864 milliliters per minute. Now when we put the patient in the sitting position, the total inflow and outflow were unchanged, and the cerebral blood flow was 736 milliliters per minute, while the sum of the outflows at J3 and vertebral veins was only 37% of this flow. In this position, in this subject, we could not measure the vertebral vein. On the left side, it could not be insonated. So it could be that it was draining a part of the cerebral blood flow, which we may be missing in numbers. The internal jugular vein flow difference between points J1 and J2 of 760 account for the remaining 63% of the blood flow, and cerebral blood flow. The cross-sectional area at J3 point again actually decreased as expected from supine to sitting position. The vertebral veins blood flow was around 27% of cerebral blood flow in supine position, but it has not been possible to measure it in the sitting position because we were not able to insonate the vein. So in the sitting position, this subject is still a jugular drainer despite position change. At J3, it was measured as 240 milliliters per minute, making it 32% of his blood flow. The vertebral veins were 32. So according to this, he would be a type 3 drainer, meaning the spinal drainer, but at the J1 point, again, we had a flow of 1,001 milliliter per minute, and making him again a jugular drainer. Our volunteer number 3 had a total inflow of about 900 milliliters per minute, and a total outflow also around 1,000 milliliters per minute. The cerebral blood flow was around 637 milliliters, making him drain 88% of cerebral blood flow through the internal jugular vein at the level J3 and the vertebral veins. We had a flow difference of almost 480 milliliters per minute, and this accounts for the remaining 12% of cerebral blood flow and the external carotid artery flow of 170. So this subject is a neck drainer if he was measured at J3 point. J3 was about 350 milliliters, but at J1 he was 1,007 milliliters per minute, again making him a type 1. In the sitting position, his outflow was almost 900 milliliters, and the total outflow was the same, almost 900 milliliters per minute. The cerebral blood flow was 626, while the sum of the outflows at J3 and the vertebral veins was 60% of the cerebral blood flow. The internal jugular vein flow difference between points J1 and J3 of 509 accounted for another 40% of the cerebral blood flow and no CBF inflow. So at J3 point, this person had around 300 milliliters. It was 50% of the cerebral blood flow, making him a type 2, a neck drainer. And again, when measured in J1 point, it was again a value of 821, making this person again a type 1 drainer. The cross-sectional area again decreased from supine to sitting as it was, in this person it was different. On his left side in the sitting position, this cross-sectional area actually was larger. The vertebral veins blood flow was around 22% of the cerebral blood flow in the supine position and 11% in the sitting position. In conclusion, we say that in this protocol, the flow was calculated based on measurements in 3 main points of the internal jugular vein, the J1, J2, and J3. Our model took into account the flow volume in the collateral network and can quantify the re-entry volume into the main collector. Consequently, this model offers an answer to the discrepancy of inflow and outflow of blood volume. The advantage of this model is quantification of blood flow volume in the collateral network. So, just the take-home part, the study enhances the importance of collateral circulation network in quantification of cerebral venous return, and with help of this hemodynamic model, we were able to calculate more coherently the amount of blood returning to internal jugular vein, vertebral veins, and the collateral network. Thanks.
Thank you. Paper's open for comment. Certainly intriguing to me for a lot of reasons. I can see that, I'd want to know what it would be in somebody with end-stage renal disease, with an excessive central vein volume, or whether you're going to move to some sort of summary formula in which you're going to try to create a sort of I can see the physics department working on this already, in which you're going to be able to give sort of one number that quantifies the entirety of somebody's sort of state, and maybe what their volume status is probably going to do for this as well. Is that where this is going?
Yes.
And also, have you thought about the external jugular in this as well, and looking at that, since it's such a
Yes, I have to say this is, I would say, the pilot study, the beginning, and the new idea that came up. And I think that actually already we got some interesting results that are different from what has been said before. But of course, the volume is in, and the other vessels that drain the blood to the main collector.
I mean, even if you don't take into account measuring at different levels, the idea of being able to sort of look at the entirety of flow as an entity from all sides has got to be more powerful than what we had such vigorous argument about, which is spot by spot by spot.
Yes, I think that by measuring first the 3 points and everything, we can really get an overall picture of the hemodynamic, let's say, make a hemodynamic assessment more complete.
That was very nice. You know, it occurred to me while you're talking that this nice measurement of collateral vessel flow. It would be very interesting to look at that with heating of the subject. Many of the patients with CCSVI and MS seem to have heat intolerance. And one wonders if there's some impairment of the reserve in the collateral venous flow in someone with CCSVI that might account for their inability to thermoregulate. Just something to think about.
Thanks for the idea.
I make one small nomenclature plea as the editor of JVIR. The low aspect of the jugular vein is not the proximal. The most proximal is actually here, because veins originate move down, but we all make this mistake. So probably better is simply to use cephalic and caudal at all points rather than proximal and distal.
Okay, just in my defense, it was something that before the last year's meeting I actually Googled and looked through all medical encyclopedias and anatomy books, and there's different, some say proximal is closer to the heart, distal is away. I know it goes with for the arterial system, but I also found it for the veins.
So you're right, and it's a problem in all journals. It's the same with catheters, the proximal and distal end, better leading and trailing. So we should really use, you're right, terms that anybody can understand.
And just to say that I did some background check on the matter, so that's why I was. Thanks.
Hi, one question. You mentioned where you measured on the jugular, but you did not mention where the location was for the vertebral.
Okay. It was between the C5 and C6, the usual place of measurement for the vertebral artery, the V2 segment.
But did you consider, because the epidurals in the vertebral section, you have the posterior drainage doesn't come in until after C6, so your below C6 would be a higher volume than at C5.
Okay.
Just something to think about.
Okay, thanks.
So I think with that, we close the session. We have a brief time for a coffee break. I want to thank all of the audience and also, the world leaders that we've had in this session today. Really spectacular stuff. We want to, on behalf of Dr. Zamboni and I, applaud you for your scholarly work, and we hope to see it in journals as well as JVR. That's my plug. Thank you very much, everyone. Next session starts at 3:40.